Well, good morning, everyone. You know, it struck me as I listened to the last discussion that there are a lot of common themes that you're going to hear over and over. So we'll do our best to add a little bit of freshness this morning. One of the things I promised our panelists is that we're going to have some audience participation the last 10, 15 minutes. So I'd like I promised my friends here that each of them will get at least one question from the audience. So please, during this discussion, think of one question. If you don't have any, I'll call on people. Well, listen, we've heard already this morning something that undoubtedly we all knew before we came in here, and that's that healthcare costs are out of control. And as an employer, you've got a situation where they're far outpacing GDP growth rates, far outpacing, in most cases, revenue growth rates, far outpacing the growth of wages, which creates a real financial mandate to manage aggressively the cost of healthcare benefits, which probably means shifting more costs to employees, and it undoubtedly means potentially reducing benefits. On the other hand, we've got to be competitive in order to attract and retain talent. And those two objectives seem in conflict. In order to reconcile that conflict going forward, I'm mindful of how Einstein defined insanity, doing the same thing over and over and expecting the same result. So this morning, we are blessed to have three excellent panelists with a wealth of experience in terms of managing and representing the interests of self-funded employers, employees, and retirees. And let me just introduce them briefly. At the far end, we've got Sally Wellborn, who most recently was the SVP of Global Benefits for Walmart, probably took care of offering benefits to more employees than most employers in the world. 2 million globally, 1.5 million in the United States. Right next to we have Beth Kuderick, who is the Chief Strategy and Financial Officer for the United Auto Workers Retirement Benefits Trust, where she's responsible for making sure that $58 billion of trust assets will take care of over 700,000 retired auto workers. And in the middle, we have Chris Chan, who's with the Mercer Innovation Labs, which is affiliated with the global consulting firm of Mercer. Chris is known internally as an innovation imagineer. I'm sure he's going to tell us a little bit about what that is, but from my perspective, he's the tip of the spear in terms of innovation and devising new approaches and best practices to improving outcomes and cost and access and convenience, and really enhancing what we heard Dr. Pearl talk about, a patient experience. So let's start out with maybe a high-level question to get your perspective and level set on what good looks like when you're talking about an employer-sponsored healthcare benefits plan. What are the attributes? What are the processes? What are the metrics? Let's just open that up and maybe start, Sally, with you.
So thanks, Mark. Thanks for inviting me here to chat this morning. So I want to make sure we think about this there's two contexts here, and this particular conference needs us to draw that out. So when I think about benefits, I think about benefit design. What is the 401k match going to be? What is the health plan offering going to be? What is the disability and the life insurance? Who's going to get it? Who's going to be enrolled? What is the administration? That's a well-managed benefit plan. Within that, then the benefits that are offered have to be delivered, i.e. health care, the 401k plan. Does the 401k plan have good investments in it, et cetera? So there's a lot of different dimensions there. Within health care, a well-managed plan is one that is offering the benefits that meet the industry needs with respect to attracting and retaining the team, the employees that the employer wants, and is done in an effective way to meet the cost issues of the company and the cost issues of the employees. That's the way I would kind of describe it, and drawing that distinction, because sometimes it gets mushed up between, do we have a good benefit program or not? And you could have a good benefit program, but be poorly delivered.
And Mary Beth, in terms of looking at your focus primarily on people who have stopped working but still have an expectation of receiving good care, how do you look at that?
Well, for us, it's similar to what Sally says, but probably a different lens and focus. as you mentioned, our members, that's what we refer to them as, our members are retired. So we take care of them and their families for the rest of their lifetime. So think of us as kind of like Medicare from a purchaser perspective. And with that, I think success is aligning what are their needs over their lifetime and their remaining lifetime from a care perspective with what can they afford from their cost-sharing perspective, because their average pension and Social Security is only around $35,000. We have 80,000 people who have pensions of less than $8,000 a year. So we have to align that, as well as with design. How can we incent the use of the best use of the benefit for its costs, be it either through the prescription drug program or the medical program, and keep it affordable for them so that they can seek the care they need. They fundamentally need care, mostly. And then picking the right partners to do business with. The payers, the insurers, the purchasers, the various programs that are out there that I'm sure many of you in the room work with as well in terms of aligning that delivery. And then very much so use and understanding of data. As much data as we can get about them. Obviously we have their claims data, we have the warehouse, et cetera, but any other data we can to help understand their needs, be it either surveys, et cetera, to be able to align with them.
Chris, presumably as the innovation Imagineer, you're dealing with a lot of employers who consult with you and maybe don't know what good looks like, and they're looking to you to help them understand what the options are. Tell us how let's just think of the last time you visited a self-funded employee who basically said, we don't know whether we're good, bad, or indifferent. Tell us how we're doing. How do you approach that?
Sure. So there are a lot of ways to answer that question. I think the most common theme that comes up, most common challenge and criticism that comes up is around engagement. Do people pay attention? Are they responsive to the message? Do they take action when they're supposed to? And time again, we see poor engagement. And I think a lot of companies are looking to benefits or their partners to help solve a lot of that engagement problem, which is true. But I think there's also a cultural challenge as well. So when an employer is pushing out a message around something, what's the response from the employee population? And unfortunately, I think there's a push-pull around the nature of work and relationships in the workplace, and financial quarterly results, and turnover, and just a lot of internal business pressure that sends mixed messages to, hey, I should take care of myself and think about wellness and well-being. And so there is some cultural shift that I think has to happen within a lot of organizations, and it's from the top down as well as from the bottom up. And so you want some executive sponsors who truly embrace and set an example, and hey, I should actually take a vacation without checking email, right? And being connected, and let my managers and their employees do the same thing. And then from the ground up, because for a lot of people, there's so much noise going on in the world, Facebook and Twitter and Instagram and all this stuff that we're connected to 24/7, we have blinders up. Like anything that's not directed and personalized to me right now, I don't pay attention to. That includes my health plan, my provider, my employer, my wellness program. And so all that is advertising and noise in the world. But if it's coming from the ground up from someone who sits across in the next cube or down the hallway who says, oh, I had this wonderful experience with this program that was offered through my employer, you should check it out because I know you're going through similar questions. That social vibrancy creates virality around messaging. And so both ways, top down and bottom up, I think are really important.
So,
So
we
Chris,
heard.
I'll just add to that, 100% agree that it is really that social connection that makes a difference. All of the programs that we had offered at Walmart, we had done all the classic communications and all the classic kinds of ways that you, quote, engage employees or associates, as we called them. And always the most effective is that peer-to-peer conversation. If it meant something to this person who I work with every day that I have a familial relationship with, because when you work together, you get sort of that familial relationship really often. That actually is the biggest driver to engagement and that trust factor. And then I think your word was virality. I'm not sure I knew that word before, but the virality of that actually, makes the program effective.
He's an Imagineer, so he can create any word he wants.
Yeah,
I have a new word now.
Yeah. Now I have to say, I travel around the country, and oftentimes I find myself at a Walmart early in the morning picking up supplies for a meeting, and it was like 7 o'clock in the morning. No one's in the store besides mostly employees, and it was like a morning radio show. I don't know if it was like that Walmart or across, multiple Walmarts. And I could sense the culture from that store because they were talking about the national stuff, but also like important things to people, employees within that community that they have, and that resonated with me. And I immediately had a connection with that store and the employees, even though it was the first time I was there. And it's like, wow, that's magical. John talked about Disney earlier. And like that magical experience, I think that's been missing a lot within healthcare. And you look at the tagline for this event, people, technology, design, the people piece has been missing a lot.
So let me ask this, and I know Mary Beth has something to say on this because your members are geographically dispersed, so engagement and communication is a challenge. But as I sit here and listen, and I'm thinking, gosh, that all sounds great, an engaged employee, but I'm thinking, for people out there that think, okay, it does sound great, what's the recipe? Tell me how to do it. That's where I would think the audience might be intrigued because it's not just one person. You can't engage an employee if you don't have a partner in communications. You can't have a partner in communications unless you have a leader that's empowered that partner in communications, and it cascades down. So what's the recipe? How have you approached that?
There's no one answer. So it's probably a recipe with a lot of ingredients, might be the way to say it. Because, as you mentioned, we are very geographically dispersed. We're in every state in the union. We have many people in Florida who probably have significant needs right now. We had people in the southern Texas area. We have 4 people in the U.S. Virgin Islands. Things like that to consider, but they're also multi-generational. So we have 50-year-old retirees with young children, and we have super centenarians. At one time, about 3 years ago, we had the oldest person in the United States in our plan. And so...
I think we had the second oldest.
All right, well, it's a contest. Somebody's got the oldest.
But they were actually still working.
There's the
Good for you. Yeah. But I think, so there's this interesting dynamic. What connects them? You can't touch them all the same way. One's not going to read a smartphone. The other one reads mail. The other one's going to depend on their children to help them read the mail. Part of our challenge is I think like 40% of them are single and alone. Okay, so they're in a survivor spouse mode. So they're in various stages of their life. And we all know as you change stages of your life, you create risk in and of itself. So there's that multi-generational aspect of it, but there's a connection. It's the community. And it's the community, in our case, of the United Auto Workers. They all have a tie to that. And in that culture that comes from it, they align with their automotive company that they came from. They have councils, union halls, networks of people, et cetera, similar to probably the Walmart store in their own way. And we try to work through those organizations and partner with that to deliver communication, as well as it's really important for us that people we deal with, our partners, our we call our carriers, our payers, our program folks, we've developed tools and training for them to understand that this is a retiree population. These are their needs. These were their life experiences before they retired. This is what's important to them as we understand it. This is how to better message them. One of our great stories early on in the trust, which just started in January of 2010, so you have to understand we're relatively new, was the initial brochure that came out with one of our carriers to start the smoking cessation program. And this is a retiree population. On the cover is a very young blonde woman. Okay, quite attractive, in a very, kind of summery kind of feel to it, et cetera. And we all look at it, and it's a brochure that's been very effective across the plans that they've used it for. And we just started laughing because it didn't align. It didn't align. And I'm sure something will align for the average Walmart, right? You're geographically, and so we know how now to talk to the folks that are in one particular area versus another area, and then within those generations. The challenge is reaching all of them because when they're retired, they're dispersed, they travel, they have snowbirds, we call them snowbirds. I forget I'm in California. You don't have snowbirds. That go from the upper Midwest, upper East Coast to Florida, Arizona every year, so we have to find them and things like that. But we overcome that, I think, through just been iteratively learning and adapting as we go. It's a longer-term approach because of the nature of what they are.
So earlier we heard Dr. Pearl talk about unit pricing, and my perspective has always been the first thing you do is try to create scale. So you create a provider network, and in exchange for volume, you extract discount. And I think we all know that there's a limit to the value of that. So then it's all about utilization. So when I think about the relationship between an engaged employee and managing utilization, I would think the best way to do that is to impose accountability, which means shifting costs, because if I'm now a payer, then as a consumer or as a patient, I will behave like a consumer. Sally, tell us a little bit about your experience there, because I know you were very innovative with the Center of Excellence program at Walmart.
Yeah, I would actually go back to some of my experiences even at Wells Fargo before that, 10 years ago, when we innovated around, consumer-directed health plans. And we had patients for the very first time, or employees at the very first time, having exposure to first dollar payment for your prescription drugs, and that sort of thing. And the question you're asking, does that change the behavior of the patient? And the short answer is the data will tell us that, that's why there's so many companies that are in consumer-directed health plans that, yes, sure, cost shifting certainly saved employers a lot of money because there has been cost shifting, but it does encourage a different kind of assessment by the patient about whether or not I actually do need treatment, whether or not I do need that drug. Should I go to this drugstore, that drugstore? Should I get generic? Should I get brand? So having the consumer engaged absolutely makes a difference. Will that in and of itself change the system? And while I had hoped, that was my hypothesis 15 years ago, my hypothesis was that when consumers understand the fact that, an orthopedic surgery in one part of the county is $25,000 and the other part of the county is $12,000, that they will become livid and the consumers will want to change the system. And they didn't. And it's kind of like what Robbie was talking about earlier, is that consumers they don't know that just because it was $25,000 doesn't imply that it was a better surgery. They don't know, just as their doctors don't know, whether it was a better surgeon or not. So the engagement is not necessarily the important engagement that is totally missing, is not on the pay side or the who pays for what. The engagement that's totally missing is asking the question of, am I going to the right doctor? Am I getting the right thing done? Does that doctor know what they're doing? So, yeah, will changing the payment model, the benefit design, because that's benefit design, will changing the benefit design drive the right behaviors? A little bit, but it's not going to change the system the way it needs to be changed today.
So getting back to an earlier comment about capitated payments, and the notion if I now as a provider am at risk, that perhaps the best thing for the patient is to avoid surgery or to avoid a complex treatment. So it does appear as though reform in how we pay providers is going to lead to
Absolutely.
reform in how we deliver care.
That's right.
Let's talk about the influence that employers, as large payers outside of Medicare and Medicaid, how can employers actually influence the rate of or the pace of change as we move from fee for service to pay for value? Chris, what do you think?
Well, I think in the world I operate in Mercer Labs, we evaluate all these emerging startups. We're like the Shark Tank function for the group. And so over the last 2.5 years, we've evaluated 400 companies in this space, all trying to solve some problem for employers. And there's well over 1,000, so we're not even halfway there. And many of these new startups are trying to sell into employers, providers, health insurers, anyone in the healthcare ecosystem. And I've had interesting conversation with them around why and how their business models adapt depending on the customer that they're trying to go after. And while health systems and insurers have massive amounts of lives, they're generally much slower to adopt and change and implement these new ideas. And so many turn to employers who still, on an annual cycle, that can be a long sales process for a new startup to try to work through. But then you get access to 5,000, 10,000, 1 million lives if you're able to partner with the right employer. And I think we're hearing from some on the panel, as well as Activision Blizzard and Google, who are thinking about some of these solutions, who the right partners are based on certain needs within their population, whether it's autism-related benefits, working moms who are having pregnancies later in life, musculoskeletal issues, cancer, like you name the condition, there's something out there that are trying to help solve something for employers.
So inherent in that is this notion, though, that over time you're going to have much more flexibility in design, many more tailored solutions. The idea of offering consumers maybe something like an a la carte menu. You get core coverage, and then you can buy up if you've got particular situations. Have you seen anyone, have you seen this kind of real flexible plan design yet, or do you think that lies ahead of us?
I've seen one that's under construction. Let me just add, and it's very much under construction, so I can't really speak about it actually, but it's a long way off, and it's very complicated, and the actuaries in the room their heads are exploding right now on some of these things. But just first, in case anyone has the misunderstanding, you could be the largest employer on the planet, which is where I was, and you still have no leverage. You have no leverage. So if anybody thinks that just because size gives you leverage, the answer is it doesn't, as an employer. The leverage lies within a lot of other entities. So relying on leverage as being, or size, or pushing the market that way is not going to solve the problem. You actually have to kind of go back the other way and look for pick your battles and think about where you can actually make a difference. How can you do something differently and not use leverage, or maybe get outside of the system that you're trying to change, right? And do it just a little bit differently. So for Walmart to actually have leverage with United or Aetna or the Blues was virtually impossible because they're way bigger than I am, right? So the message that I would share with the employers in the room and the partners that are seeking to work with the employers of the room is it doesn't require size, it requires chutzpah, I guess is the first word that comes to my mind. It requires a little bit of energy of trying something different and doing it, not necessarily waiting for the size or the leverage of a big carrier, not waiting for your, being able to change the big carrier, because that's not going to happen, but it requires changing something separately, differently, and focusing on it from a different angle and not trying to just change the whole system.
So you both strike me as having a little chutzpah, so why don't you give us some examples?
Go ahead.
I'd just like to comment a little bit further, and then I will. I totally echo what Sally says. I mean, we largest purchaser of retiree healthcare in the country. We started 10 years ago with over 900,000 people. It doesn't matter. I cannot influence certain things. But despite all that, I think it's a question of what's your goal. I know that if our goal in our perspective obviously is to maintain affordability, ensure the sustainability of the assets that we have to pay for the care for the retirees over their lifetime, as well as run the plan well and deliver what they need, we've been able to iteratively bring change in that if you focus on things either geographically or identifying a specific need and then organically growing it and aligning with someone to deliver it out has been very helpful to us. And for us, what's really interesting, and because you mentioned the consumer-directed plan, and obviously price can motivate members or patients or consumers, as you refer to them as, even though they don't have all the tools in front of them that any consumer in the country does for all the reasons Dr. Pearl talked about. That can motivate. It's so hard to navigate. It is so hard. But what we've found is there's the community aspect that these folks that are in our trust, many understand it's their assets. And the same thing to some extent from an employer, because not quite as much, but it's affecting the company's performance. The degree of dollars that have to be spent on healthcare. Well, in the trust, it's basically their assets. And so we've engaged them to say, in Indiana, we've said, please go to a reference lab. And Indiana had a very unusual situation where all the lab work was being done in facilities with incredibly multiplied levels of costs for normalized blood tests, for example. We offered them an incentive to do that. We gave them a tool to know where to go. We did that, and we saw immediate change. What was fascinating was, all of a sudden, and I don't think this will surprise Sally, the pricing mechanism started to change. There didn't seem to be the need to charge as much for those complete blood counts, et cetera. This is my view, so I'm not speaking for the trust. I think it's throwing pebbles in a pond and watching the ripples just keep getting bigger and bigger and bigger. And there's not one big rock. There's a lot of pebbles. And I think what employers can do is do those types of things, but it's going to take a community of action, but it's not that leverage. Now, we do have one place, I think to get to your point, where when you buy something that's more of a commodity. So think of from our perspective, we're able to bring scale to purchases of prescription drugs. We have a single PBM, pharmacy benefit manager, for whom we buy drugs through. We are a very important contract to them. We can establish and negotiate our pricing. We can establish and negotiate transparency, et cetera. We can ensure efficient delivery, et cetera. That's more of a, the same Lipitor is there is the same Lipitor is here. I pay a national price. That's leverage. And so for us, when we can do that, we exercise that. It's transparent to the member. That's not coming out of their pocket. I like to refer to it as having someone else pay for it. But that's much more difficult in any kind of normalized medical care delivery that's out there. We also, I think another area where we influence, or we attempt to influence, is in two spaces. 77% of our people are in Medicare. That doesn't mean I don't have a lot of costs for them. I have a lot of full coverage of their drug costs, their dental costs, as well as a wrap of their medical benefit. We also encourage them to be a part of Medicare Advantage plans. And we have a big process ongoing today, right now, to do that for next year. But we also work with various partners and communities of engaged people to influence what CMS does. Because what CMS does helps sets the standard for everything else. And there's some, depending on the way the laws are written and CMS's point of view versus kind of what you would think would be logical from an employer or purchaser perspective, there's a way to sometimes align those things. And we've had some successes. As well as when you have $56 billion in assets, you have a pretty strong corporate governance function and the ability to understand and work with pharma around good corporate governance and their processes, understanding the use of biosimilars, encouraging those laws and regulations across the states, especially medication area, which is such a high risk and high growth area for anybody. Those are the types of things we can do and engage with as well.
So the visual of pebbles and ripples, it's my big takeaway from this conversation. Thank you. But as we think about the number of companies, you said hundreds or maybe even thousands of emerging companies fueled by entrepreneurs trying to solve these problems, it now starts to resonate that each one of these pebbles is potentially a solution, a value-added solution, maybe a business. I mean, maybe we just, in the remaining minutes before we get the audience involved, maybe come up with an example of one of those pebbles and the ripple effect, whether it's telemedicine, whether it's transparency, cost and quality tools, whether it's concierge medicine. Why don't we start with you, Sally?
So, in my point of view, the biggest thing that we need to solve in the healthcare system in order to be able to have the money that America needs to be able to have health insurance coverage, pay for healthcare for all Americans, is we have to eliminate the inappropriate care, the misdiagnosis, the care that's just totally not necessary. And Robbie talked about it. That's 30%. 30% could be taken off the top if the doctors would just do what they said, not 30% for choosing wisely, but if the doctors would just follow what they said in choosing wisely, we could take 10% out of the healthcare cost. But the doctors aren't even doing what they said they should do in choosing wisely. So a couple of the places where I've seen making some movement, helping employers get to helping their employees, patients, avoid that inappropriate care are through programs like Grand Round, Second MD, which is the, I don't want to call it concierge medicine, I will call it second opinion kind of medicine, but it's actually not just second opinion, it's actually finding clinicians who are expert in their space, who are committed. So it's an intellectual commitment to practicing care that is appropriate. So it's more than just practicing care, practicing medicine. You could be the best heart surgeon in America, right? By every measure, every quality measure, no complications or whatever. But if you're doing heart surgery on people that don't need it, you're actually practicing inappropriate care.
And so let me just maybe push on that simply because I believe, and I'm sure if there are physicians in the audience, I have some in the family that understand what you're saying, but is it they're practicing inappropriate care because there's a data problem or there's an issue with clinical decision support at the point of care, as opposed to, well, I'm a businessman or businesswoman, and if I deliver this additional unit.
I actually don't believe that the doctors are doing it thinking if I do one more surgery, I'm going to make more money. Yes, there are a handful of those. There's no question about that. We saw that up in, up north 10, 15 years ago, right? But that's not the big driver. It's more about it's practice patterns. It's I'm a surgeon and a patient has been referred to me for surgery, so what am I going to do? I'm going to do surgery, right? And what am I paid for? I'm paid for doing surgery. I'm not paid for assessing this patient for whether or not they do surgery. So we take ownership or responsibility for we've been paying for it wrong. So it's not that they're just doing it because they should, and it's not necessarily, although some doctors would say, or some providers would say it's to avoid malpractice, that actually isn't it. It's just, that's the way they've always practiced. They don't have access to evidence-based medicine. They don't have any, how can they possibly keep up with everything they need to keep up with in the evolving medical field, right? And they aren't using their, the EMRs are not set up to give them information in the right way at the right time to say, hey, did you know you should change this now? So there's a lot, the whole system is not supporting those decisions.
Chris, how about you?
I mean, speaking of pebbles, you had Amazon post a job with a reference to pharmaceutical expertise early this summer, and that had the ripple effect of -4 and 7% on, ESI and CVS. And so I think one of the things that we're going to see is new entrants, non-traditional competitors into the healthcare space, whether it's Amazon, Apple, Google, Facebook, who have a relationship with consumers and are trying to help reposition that to patients. And I always thought about Walmart's role in delivering primary care and having your clinics in those communities. And so you got tech-based and physical, in-person new competition within this space. And I think those are going to create huge ripple effects on the overall infrastructure.
So just to add to your question, and Robbie said this, the doctors don't have any idea about who they should refer to either, right? And so that transparency amongst themselves and amongst us about where the highest quality is and where that quality is culturally aligned with only doing appropriate care is the biggest black box we have right now.
Well, Sally stole my answer.
Oh, so sorry.
I was going to.
Well, I'm glad we
I guess
agree.
I don't mean it. I think the ability and one of the most amazing things about working in this space is it's so personal. We all talk about healthcare, but we all experience it. We all experience it in our own ways. We all have the stories, like Dr. Pearl talked about. So I think when I think about our members, whether it's the 700,000 or the ones that I see that have had the challenges that have been referred to here and that we end up still paying for because that's what we do. To me, it's the transparency and understanding of how to navigate the system. And with that, knowing that when they do get sent or choose, or really do they understand, as incredibly well said, is it really a choice? You go to your doctor, he says, go here, you're going to argue about it? In all reality, you're more passively engaged. Do they understand what's going to happen? And what does it mean? And what's the success factor in terms of your definition of what that outcome is? It may be, I want to do these things with my grandchildren. It may not be what that surgeon may think that outcome should be. And how do you align that? How do you give them data? How does your, as you say, your referring physician knows it's the right place? How do you just take the time to ask the questions and capture what it is they want and need, and is this going to work? And then for the people that are in it, they understand along the way where they're going and why. It's just that level of transparency. That's the outcome level of transparency, the quality of the delivery, the measurement of the element of transparency. Then with it, the cost transparency, the fundamental cost transparency, and the confusions around all that for plans, especially that have a lot more network challenge, that bring more narrow networks, et cetera, and the confusion that can reign. I think that's where we should focus. That's where we should focus.
It is interesting, and I want to go to the audience, but I want to just make an observation, hearing the need for transparency, but also understanding that medicine and the patient-doctor relationship is still one that is of trust. So as we think about increased transparency and knowing that I can go over here for X and over here it costs X plus, but I don't have a relationship with that provider, or if I have the ability through technology to engage with a doctor on demand, or to go to a lower cost venue like an urgent clinic, it seems still as though fundamentally, even though we will have technology and data at our grasps, that fundamentally the relationship that's shared between the caregiver and the patient is still such that it's going to take a lot more time to evolve. And that therein lies, I think, why last night when we were chatting, I used an airplane analogy and said, well, if you're going through the year and you're looking at your data, understanding your trend, understanding your level of engagement, tell me the dials that you could change to, and I think Sally said, oh, this isn't an airplane, it's a tanker. And I said something like, well, let's change the boat analogy to a sailboat. Can you trim the sheets? What can you do? And I think maybe one of the things that I've learned from this discussion is patience is required. because it's not going to happen quickly.
I don't want you to walk away with the perspective that I'm talking just about price here. Because to me, the transparency really is in the navigation and delivery of the care and the understanding of where you're going. I mean, it starts with things as simple, and you heard choosing wisely this morning, and the answer. We gave 400,000 of our members a card that says these are the 5 questions you need to ask your physician. I mean, we got to go back to basics. And these are things like, how much is it? Do I really need this? It's the basic questions. We've spanned that out across the country. We have people calling in wanting cards to give their family members because they're not understanding what's happening and why sometimes, and what's really behind the choices I'm making and what are my choices. And I think that's also a big part of the transparency I'm speaking about.
I think I saw one hand, so you get the privilege of the first question.
Sorry, we have a mic
he's got a
here,
mic
just
right
for the live stream.
Thank you. This is Andy Gaze from Health Tech Capital. I'd like to go back to the Pebble story. So Sally, Pebble versus the rock in the pound. I mean, you, for example, how do you make a decision between making a deal with Cleveland Clinic for all the open heart patients there and going directly to the best care providers versus, working with a small startup that has a better product for pain management or one of the multiple ones for baby management? How do you make those decisions? Because it's somewhat easier to do, but the cost is not the same impact. I mean, how do you figure this out?
Yeah. So we chose to focus on, it's the 80-20 thing, right? We've decided to focus on the 20% of the patients that drive 80% of the cost. That was just the way we did it first. And so that was the reason we focused on anecdotally what we were hearing about the horrible care that some of our patients were getting and focused on identifying the highest quality providers that we could find for certain procedures and who were culturally aligned to only providing the right care. And we developed a bundled payment so that they were paid for both providing the care if it was necessary or making a team-based, and this is important, Robbie mentioned a team-based decision about if the care is not necessary, how to manage the condition, because there still is a condition, how to manage the condition going forward without doing potentially surgery or whatever. So we decided at Walmart to focus on that piece first, but having said that, we didn't take our eye off the ball about, hey, there's, Virta Health being developed out there that's a nutrition-based way to cure diabetes, right? So you got to keep the eye on the ball of all of those kinds of things. But truthfully, honestly, Walmart has a lot of employees and not a lot of them are in the benefits department. And so we had to make our choices about where the most important time is spent.
And a quick follow-up question. What's the role of the GIF, the Virgin Pulse, all those guys who are trying to become the expert that aggregate for you those best practice, which in some ways is a barrier to innovation?
Say the question differently. Are you asking, were those a barrier to innovation?
No, I mean, most of Walmart is unique because you can't afford to have a lot of people experimenting, but most VP of HR don't have people to investigate all these different new approaches there.
Right.
So there has been an effort for people like Jeff, Caslight, to become the one that does the testing and make the recommendation and integrate them together as opposed to the employer making themselves their own pilots.
Yeah, I think that there is a role for that. Those, as they continue to develop and build their platforms out and have the right analytics to support for the employers that won't be able to make a bet on the come, right? So that's a big challenge in the employer space where they can't just make a bet. They have to actually be pretty certain that whatever they're investing in is going to give them the return that they need. I think it really is the juxtaposition, as we were talking about before, the consumer engagement, how much we want the engagement, and how much help we're going to provide the consumer, guidance we're going to provide the consumer so that the patient doesn't have to actually become the expert.
I mean, we've recently, this is not what I would call scraping leading edge innovation, but engaging care navigators for our highest cost people. And one thing I would say to you, in addition to the actual navigation, the help of the actual people that are going through these much more traumatic situations, both at high risk, and we've tried to elevate it down, take it down into the more moderate risk level, is as a design and as a plan, we've also been taking away from all those individual stories that we hear about a lot of things that we can then feed back into our design to help improve things. We've learned, we didn't realize we didn't cover that, we didn't realize that was how difficult that was to do. And so I think the more you can get out and engage and try and understand their individual experiences, and how can those individual experiences, those people who need the most help and navigation, to improve for the all. And I think that can be done on a small level, and it can affect a large group of people.
We probably have time for one more question. Okay.
Hi, thank you for this wonderful panel. My name is Sangeeta. I'm founder of HelpSee, and I'm an integrative medicine researcher in symptom management, and I'm a cancer nurse. So what I have seen is that a lot of evidence-based integrative modalities are extremely effective when it comes to symptom management and when it comes to long-term care. Between 40 to 80% improvement in symptoms without using herbal remedies, I'm talking about. And these we have looked at larger populations too and seen it to be effective. What can we do to encourage more of these modalities and more coverage for these for our employees, for our people, because it leads to significant reduction in cost between thousands of dollars and less than $50 in many, many cases.
Well, I think obviously seeing those results is helpful over time, over enough of a large population. And then, what's the employer's role in helping deliver that? Does that need to be integrated with providers also delivering care, whether it's treating physicians or nurses or other care team members? How does that business model scale? How is it priced? Can you provide coverage to 1 million lives? How does that break the system? What are the pitfalls there? And so probably easier for smaller employers in more geographically focused areas, but certainly I think pebbles like that can have ripple effects on the entire ecosystem.
Thanks very much for that question, and my sign is saying we're out of time, so join me in thanking this panel. Thank you very much.